Hello, I'm Patrick Campbell, and this is my presentation on the confused patient. The first question that it is important to clarify about is, what am I mean by the term confused? This can be used in a wide variety of settings by patients and non-specifically, but in this presentation I'm referring to reduced mental clarity, coherence, comprehension, and reasoning. Now, before moving on to anything about the confused patient, we must first, of course, go through A, B, C, D, checking the airways, breathing, circulation, and then for disability, before moving on to taking a history. But this can be problematic in the confused patient. They may be unable to recall facts and dates accurately. It's therefore wise to first of all assess whether the patient can understand what you're saying and whether they can recall time, place, or person. If you want to investigate their confusion more in depth, there are a few tools which you can use. These include the abbreviated mental test score, and the mini mental state examination to quantify the levels of confusion. After doing this, it may seem wise to try and get a collateral historian to support the patient's account of their illness. Although I have defined what confusion means in the context of this presentation, it is important to understand what the patient is meaning by their confusion, and in particular, whether this is a new problem or a long-term one. What is their normal level of functioning? I'm going to briefly look into the chronic causes of confusion before delving deeper into the acute causes. Chronic causes are mainly dementias, syndromes characterized by progressive, usually irreversible, global cognitive deficits. Differential diagnoses include things such as depression, amnesic disorders, and learning disabilities, as well as a few other things. Reversible causes of dementia are also important to remember, as they can be treated and the patient's dementia potentially cured. Now, moving on to the acute causes of confusion, the first type of confusion we're going to think about is delirium. This is a transient global disorder of cognition and consciousness, synonymous with the confused elderly patient almost. But other differentials include psychosis, isolated amnesias, and aphasias. These are important to think about. Psychosis can be identified by the preserved recent memory. The patient might be orientated to time and place but not person, and auditory hallucinations may be the main feature of the history rather than visual auditory hallucinations common in delirium. The personal history of psychosis is also a useful indicator. Differentials inside psychosis include schizophrenia, psychotic depression, schizoaffective disorder, and substance-induced psychotic disorder. Isolated amnesias involve loss of long-term memory, typically after traumatic event, whilst having preserved recent memory. These patients will have no memory of their identity, but their attention will be retained, and their short-term memory of events potentially still present. The two main differentials in this category are traumatic brain injury and psychogenic amnesia. Aphasia is the disturbance of comprehension and expression of language caused by dysfunction in the brain. This can be either acute from causes such as stroke or chronic. What you're looking for here is a focal deficit in the patient's speech. What can help to identify this is asking the patient to follow a 3-step command, which they may be able to do in expressive dysphasia, or name 3 common objects, which might be possible in receptive dysphasia. Moving back into delirium, there are a few key features which can really help you identify the delirious patient. These include disorientation, abnormal vital signs, clouded consciousness, age over 40, and no previous history of mental illness. Now, the problem with delirium is that there is a very wide range of differential diagnoses. These include infectious causes, such as urinary tract infection and chest infection, neoplastic disorders such as brain tumours, vascular problems including stroke, MI and heart failure, rare immune causes such as neuropsychiatric lupus, trauma causing subdural or extradural hematoma, endocrine causes such as thyroid problems or diabetic ketoacidosis, drugs, alcohol, digoxin and diuretics, metabolic causes such as chronic hypoxia from COPD, degenerative disorders such as dementia can predispose. One thing which can help narrow down these differential diagnoses is by age. All patients will typically present with acute infections, chronic disease, cancer, stroke, dementia, which is decompensated after things such as infection, and problems from polypharmacy. Whereas young patients may more likely have trauma, drug overdoses, and endocrine problems. The first thing to do, I guess, is do a systems review, looking for any symptoms which the patient may have, which can point you in the direction of the problem. Pain can be a very helpful one, and even a very demented patient might be able to complain of chest pain. Fever can help point towards infection, and chest symptoms, things such as pneumonia and chronic COPD. Urinary symptoms may point you in the direction of a urinary tract infection, and GI symptoms such as pain and changing bowel habits might suggest diverticulitis. Photophobia may be a feature of meningitis and septicemia, and any recent trauma is important in the diagnosis of extradural and subdural hematomas. Neurological symptoms should be sought out for similar reasons, and brain tumours, of course. Looking at the past medical history can be helpful. Things such as chronic diseases like COPD and heart failure can lead to confusion in end stages. Cancer, dementia predisposing to delirium, diabetes, particularly diabetic ketoacidosis, thyroid, and epilepsy. The patient may be post-seizure and therefore confused. Looking into the drug history, elderly patients may have polypharmacy, but it's important to especially look for things like digoxin and diuretics. Withdrawal from prescription drugs like benzodiazepines and steroids can also cause confusion, as of course can illicit drugs. Moving on to the social history, alcoholism is a very important thing to pick up on for Wernicke's encephalopathy. Drug users, overdosing, mental health problems, and previous suicide attempts may again suggest the patient has attempted an overdose. I hope this presentation has helped to give you a good overview of what to look for in the confused patients, but I must warn you, it is far from exhaustive. Thank you for watching.